In the fourth section of our lecture, now we will talk about some specific viral etiologies. What are the differential diagnoses that can be confused with specific viral meningitis etiologies, and also specific viral infections. So it's very important that we should know in detail differential diagnosis. What are some other conditions that can be confused with the viral meningitis, and some common specific viruses that can cause viral meningitis. So differential diagnosis. Diseases which mimic the viral meningitis. We have untreated or partially treated bacterial meningitis. So if the bacterial meningitis is untreated or partially untreated, that can also be mimicked with the viral meningitis. Another is early stages of meningitis by fungi or Treponema pallidum. Meningitis by Mycoplasma, Listeria, Brucella. Parameningeal infections, or the infections surrounding the meningeal area. Neoplastic meningitis. Meningitis secondary to non-infectious inflammatory diseases. So all these are the conditions. To treat the patient properly, we need to properly know, accurately know what the diagnosis is, or what are the causes of the meningitis or cause of the meningitis. We should differentiate the viral meningitis from all these different conditions so we can properly manage the people. So different conditions causing meningitis should be differentiated from viral meningitis. Variety of clinical algorithm, presence of cerebrospinal fluid protein, elevated serum calcitonin levels, bacterial meningitis score. Probability of bacterial meningitis is 0.3% or less in those with negative cerebrospinal gram stain. Usually bacterial meningitis or meningitis which is caused by bacteria, they show positive gram stain. If the negative gram stain, then usually that is very, very unlikely that it is due to the bacterial meningitis. CSF neutrophil count, if it's less than 1000 cells per microliter, again, it's very, very rare that it might be due to bacterial meningitis. CSF protein level less than 80 milligram per deciliter. Peripheral absolute neutrophil count of less than 10,000. So these are some very important features that gives the clue that it is very less likely that it might be due to bacteria. And no prior history or current seizures, then it's very, very unlikely. So this is some important characteristics that concludes our bacterial type of meningitis, or that decreases the likelihood that it might be due to bacterial meningitis. Specific viral etiology. Specific viral causes are enteroviruses. Enteroviruses is the most common cause of a viral meningitis. Enterovirus. More than 80% cases, specific etiology is identified. Sporadic or occur in clusters. EV71 produced large epidemics. So enterovirus 71. Lot of people are affected when they are affected by the enterovirus 71. So it occurs in epidemics. Likely cause in summer and fall, especially in children less than 15 years. So specific cause, viral etiology, most common is enterovirus, affects mostly the children less than 15 years, common in summer and fall season, and it is usually cause epidemics. It occurs in the big area or population. Incidence decline with increasing age. Meningitis outside neonatal period is usually benign. So it's more common in the children below 15 years of age. As the age increases, there is less likelihood of getting enterovirus meningitis. Next, physical examination of the patient should include a careful search for the stigmata of enterovirus infection like exanthems, hand, foot, mouth disease, herpengenia, pleurodynia, mycopericarditis, and hemorrhagic conjunctivitis. All these are different conditions that are associated with enterovirus infection. On physical examination, we should look for all these different conditions. That gives us the idea that this might be the enterovirus meningitis, especially if it's children below 15 years of the age. Look for hand, foot, mouth disease, any exanthems on the skin, pleurodynia, myopericarditis in the pericardium. If there is inflammation of the pericardium layer surrounding the heart, and there is conjunctivitis, all these are very common in the enteroviral infections, so should be looked for in physical examination. Next, CSF profile associated with specific viral infections. Lymphocytic pleocytosis, mainly the lymphocyte is the predominant cell. Normal glucose level, normal or mildly high protein concentration. 15% of the patient, they have normal CSF leukocyte count. CSF reactive transcriptase polymerase chain reaction is used for the diagnosis. Arbovirus infections, mainly in summer and early fall. Western Nile virus epidemics, sentinel infections, arbovirus meningoencephalitis. Now, what are some characteristic features of arbovirus? There is cerebrospinal fluid lymphocytic pleocytosis, normal glucose concentration, mildly elevated protein, and 45% have CSF neutrophilia. So these are some features associated with arbovirus infections. Distinguishing parameters are the rarity of hypoglycemia in WNV infection, absence of positive gram stains, negative cultures. Arbovirus infection, again, there is demonstration of viral specific IgM in cerebrospinal fluid, seroconversion. Cerebrospinal fluid IgM increase progressively as the disease progresses, and it peaks in those with neuroinvasive disease. CSF polymerase chain test with arbovirus infection, WNV CSF polymerase chain reaction sensitivity is 70%, is less than 70% serology. So it's less than, it's not very sensitive. It's less than 70% as compared to serology. So sensitivity is less. Next, herpes simplex virus meningitis, major cause in adults, uncomplicated meningitis cases due to herpes simplex virus type 2. Type 1, 90% of herpes simplex and encephalitis. So type 2 is not commonly associated with complications. Type 1 can cause encephalitis. Diagnosis is by the polymerase chain reaction. Cultures may be negative, that's why we need polymerase chain reaction. Demonstration of intrathecal synthesis of herpes simplex virus specific antibody. And diagnostic clue is the presence of herpes simplex virus genital lesions. So if genital lesions are present associated with herpes simplex virus, that's very, very characteristic of the herpes simplex virus associated meningitis. Next, varicella-zoster virus meningitis. Suspected if there is presence of chickenpox or shingles. Important cause of meningitis and encephalitis without rashes. So if there is measles and chickenpox and shingles present, we should suspect that it is due to varicella-zoster virus. Frequency is extremely variable. Frequency is not fixed. Diagnosis again is by polymerase chain reaction. Serological studies show, serologic studies complement the polymerase chain testing, demonstrating specific antibody in intrathecal antibodies, and there is IgM antibodies on serological testing present. Positive CSF cultures associated with varicella-zoster virus meningitis. Next, Epstein-Barr virus, EBV virus infections produce aseptic meningitis with or without infectious mononucleosis. So Epstein-Barr virus is a cause of infectious mononucleosis. So this meningitis can be with or without the infectious mononucleosis. Atypical lymphocytes is present in cerebrospinal fluid, never cultured from cerebrospinal fluid. Presence of acute infection by serum and cerebrospinal fluid serology. Serum and CSF serology shows IgM antibodies to early antigens, absence of antibodies to Epstein-Barr virus associated nuclear antigen. Polymerase chain reaction false positive, result reflect viral reactivation. Next, HIV meningitis. HIV meningitis, there is risk factors for HIV infection. Following primary infection with HIV in 5 to 10% of the cases, less commonly at later stages of illness. So primary infection is associated in 5 to 10%, but as the stage progress, disease progress, chances are less. Cranial nerve palsies are commonly associated with HIV meningitis. Diagnosis is by detection of HIV genome in blood or cerebrospinal fluid. Seroconversion may be delayed. Next, the mumps virus in late winter or early spring season, especially in males. Vaccine is available for this live attenuated mumps vaccine. Presence of parotitis. Mumps is very commonly associated with it can cause sterility in males, cause orchitis and different complications. So it can cause parotitis, inflammation of the parotid glands, orchitis, euphoritis, pancreatitis, or elevation of lipase and amylase. Mumps CSF pleocytosis exceed 1000 cells per microliter in 25%. Lymphocytes predominate in 75%. CSF neutrophilia in 25% and hypoglycemia in 10 to 30% of patients clue to the diagnosis. So these are different findings of the cells level if the infection is due to mumps virus. Diagnosis is culture of the virus from CSF, detecting IgM antibodies, seroconversion, polymerase chain reaction can also be used. LCMV infection. When aseptic meningitis occur in late fall or winter, in those with history of exposure to house mice, pet or lab rodents exposure to their excreta, then LCMV infection is suspected in all these different conditions. Features, we have rash, alopecia, parotitis, orchitis, myopericarditis, pulmonary infiltrates. These are all the features associated with LCMV infection. Diagnosis is presence of leukopenia, LCMV infection, less number of leukocytes, leukopenia is present. Presence of thrombocytopenia, thrombocytes are also decreased. LFTs are abnormal, liver function test. Marked CSF pleocytosis, more than 1000 cells. Hypoglycemia, less than 30%. Diagnosis of LCMV based on serology, culture of virus from cerebrospinal fluid. So that was all about the specific viral etiologies, and we discussed in detail all these specific viruses that can cause meningitis, and we talked in detail how we can diagnose and what are different tests that should be performed for the diagnosis of those specific viral etiologies. Thank you for watching sqadia.com.